to your point, you know, there is a real delta and difference between the historically represented populations and the underrepresented populations. So the data shows that you were overwhelmed from managing your life, like care itself, or caregiving responsibilities. And 50% of our respondents felt like that was a huge issue. And there's a delta between the underrepresented and the represented populations. So when I look at that particular theme, the historically represented or historically served population, about 42% of our data set in that group felt this way.
Hey guys, welcome to another episode of the Being Rare podcast. So today I am sitting down with Jenifer Waldrop, the Executive Director of the Rare Disease Diversity Coalition, or the RDDC, at the Black Women's Health Imperative, or BWHI. Jenifer joined the organization in October of 2022, and under her leadership, RDDC has spearheaded some initiatives across the rare disease treatment continuum. Jenifer's career spans across corporate, nonprofit, and international domains, and she has designed and implemented equity-centric frameworks for Fortune 500 companies across Asia, Canada, and the United States. I do want to highlight that Jenifer is passionate about inspiring leaders to challenge inequities and drive scientific and policy advancements to elevate marginalized voices in healthcare. Jenifer, welcome to the Being Rare podcast.
Thank you. Thank you for asking me to join your amazing podcast.
Oh, yeah, absolutely. Absolutely. So today we are talking about the Inequities in the Rare Disease Community Report, which was a collaboration project with NORD, the National Organization for Rare Diseases, and RDDC, specifically the Patient and Caregiver Working Group, to which I happen to be a part of. And so I really wanted to kind of start with the background of the report. And just give a little background to the audience first. Rare diseases impact small patient populations or fewer than 200,000 people. That's here in the United States, which makes it difficult to diagnose and even get access to care, clinical care, and even treatment. There are more than 10,000 different rare diseases that we know of, and 95% of those rare diseases lack an FDA approved treatment. And so just wanted to kind of give a little history, if you will, to those who may not be familiar with what makes a diagnosis rare. So starting off with the report, what was the motivation behind conducting this survey? Like, were there any specific trends or gaps that made this study important to do?
Sure. That's a really great question, because that's the question that we asked ourselves at the coalition before we even went forward and figured out the methodology of creating this survey. So as you mentioned, the National Organization for Rare Disorders, NORD, is an organization that's been around for 41 years. They're so instrumental in the Orphan Drug Act, which is essentially, the backbone when we think about rare diseases and rare disease treatments. That being said, that organization has seen a lot in 40 years, where RDDC will only have been around 5 years in May of this year. So our viewpoints, our experiences are very different. And as NORD is a coalition member, just like you all are a coalition member, we looked around and said, what information is lacking out there that's really important for the rare disease community? And even more importantly, when we think about the historically marginalized, underserved populations, do we have truly their perspective in understanding their lived experiences, our healthcare here in the United States, and a number of other things that impact the survey itself? So when the working group got together, they realized that they could make a difference it can make a difference in this report that they gather this information and then it would be helpful for other patient advocacy organizations such as yours as well as NORD. We realized that we had something there. So the
Mhm.
why and how we got started is because within this working group, and I think at that point there was probably close to 50 members, if you remember a couple of years ago when it was a smaller working group. I think with all those brilliant minds and those amazing experiences, they all came to consensus and said, this is absolutely something that we need to do and that we need to do not just for our patient advocacy organizations, but for the industry and for government as well. So I think there were so many different reasons how we started with this, and knowing that when we did a landscape of rare disease and that term diversity of
Mhm.
populations, this is why we created that survey because it wasn't there already.
Yeah, yeah. And so we'll talk a little bit about the key findings in just a little bit. But, thinking about what this survey may reveal, who was the target audience for that? Like, who do you hope will take this information and use it?
Yes. So I believe that originally when we started with the audience, it was really thinking about the coalition members and what we heard from the members as to what there was a gap out there. So for the members, and our members are made up of mostly patient advocacy organizations and the pharmaceutical biotech corporations. But we do have a handful of other people in other industries like we've got a great relationship with federal agencies like the FDA and NIH, as well as healthcare, hospital systems, and others as a part of the coalition. So, we had enough of that armchair data to say, well, at the very least, our coalition members and NORD's contacts
Mhm.
would benefit from this information. However, since we've actually revealed this information, it's actually been found really useful, not just from the center of rare disease and this community of the patients, the caregivers, because what I'm finding is folks are seeing themselves in this data, even though they themselves may not have personally answered the question. They
Mhm.
realize that when they see the results, it resonates with them. So we have, that population as an example, but we're also using it to educate other people. We're using it to educate providers. We're using it to educate journalists. So anybody like in the media can use this information as part of their data set. So I would say that if you believe in science and if you believe in data collection, then this information goes out to just about anybody. And to your point about the rare disease community, we are unique and we are small in some ways. So it provides so many aha moments for folks because so many people are not familiar with just the rare disease topic itself.
Yeah, yeah. I will say, I remember once the survey was actually completed, there was an opportunity for beta testing, and I was actually one of the ones who participated in the beta test. Why was it important to have that period, that beta testing window before it was made public for people to actually respond to it?
Yes, so great question. So I have to say a few different reasons. One is honestly, I don't take this job as the executive director for the RDDC lightly, meaning I bring these skills that I have collected in my career from working in both for-profit as well as for other nonprofits. And one of the things that was pretty evident to me when we first started looking at the questions was wondering if it was going to land really well to the historically underserved and underrepresented populations, knowing that there's a lot of headwinds that are faced in those
Mhm.
organizations when it comes to healthcare. And so, because we had targets to reach, and we knew that we wanted the survey to actually have responders, we wanted people to actually not just say, okay, I got that survey and that's nice. We wanted folks that look like you and me to actually respond to that survey. So,
Yeah.
communication is huge. So, and you do that through one of the ways you do that through is the way that you set up the survey, and then, of course, the survey questions itself. So I did ask the group before we went out and publicly brought this out nationwide. Let's look at the questions one more time through the lens of cultural humility, ensuring that it will land to all populations. And then
Mm-hmm.
let's target certain groups to be the friendly, what we like to call in the for-profit world, our friendlies, to help us look at the questions, provide some critical feedback so that we don't get egg on our face when we actually
Yeah.
bring it out nationwide. So I believe in piloting work, beta testing work before we do it larger. And to your point, I think working for a nonprofit, it's important that we steward the money in the most responsible way. And for me, I felt like it was better to slow down before we could speed up and test before we could launch.
Yeah, I love that. I think that's so important. And bringing those perspectives in, is a great segue to, kind of that methodology that I wanted to kind of, touch on too. So can you walk us through how the survey was conducted and, who participated, why you took the approach that you took to make sure, um, people would respond. It's a survey to really absorb the perspectives of underrepresented communities and people who may not often participate in research or answer surveys and all the stuff. Why was the approach here so targeted, and how did you actually go about making sure those folks answered?
Sure, absolutely. Um, so I would say a couple of ways. So for the survey methodology and preparing for this information, when we think about diversity, often folks think about it, even underrepresented, the term underrepresented populations, we often think about it through the lens of race and ethnicity, but really
Mm-hmm.
that definition is much broader, especially in healthcare. The definition that we use for underserved communities includes both the race and ethnicity component, but it also includes the LGBTQ plus category. We also look at it through the lens of social economic status and
Yeah.
or like the federal poverty level concerns. And then we also look at it through the lens of rural residents because access, right? So access is in the rural communities, often there is a difference between that and the urban communities. So that broader definition was top of mind as we were doing the survey. And I just want to put that out there that when we think about the underserved populations, we encompass all of those different types of populations and recognizing that there's intersection, right? That's not
Yeah.
just the only one of each of those categories, because you could be
Mm-hmm.
a part of all those categories, as an example. So that was part of as we were identifying the methodology. And for us, partnering up with not just NORD, because NORD has quite a bit of resources. They've got a great marketing team. They have quite a bit of experiences. They have a little bit more bandwidth than we do at the
Yeah.
Black Women's Health Imperative, right? So there's a number of reasons. So being a larger entity and and around the block longer than we have, I think
Yeah.
those were a number of different reasons why we chose NORD. And then working with their amazing data team, we collectively discussed one, what type of survey instrument were we going to use? Two, what languages, thinking about it here in the United States, was important. And then three, the longer game is once we collected the data, are we able to interpret it in the various languages in real time? So what often happens, so this is a whole, if anyone has ever studied data science and surveying, it's a whole school of thought there. And so sometimes what happens if you're not so familiar with some of that work is you'll start off in English because that is, our business language in this country.
Mm-hmm.
But then you'll do something like in Spanish and you'll use them almost like an other. So then when you're looking at the data, it feels like you're looking at a different set of population. And that also takes additional time and what have you. We wanted to ensure that it was going to be as efficient as possible and feeling like all groups belonged into this data set as seamless as possible. So part of the survey instrument that we landed on, which was SurveyMonkey, quite honestly, we wanted to ensure that the data that we were collecting, that we were going to look at it, and the person that was going to analyze it for us, it didn't matter if they had Spanish proficiency or not, that they were going to see it in kind of that real time in English, because that was, that is the language. So that was
Mm-hmm.
part of the thinking too, is ensuring that the answers that we received was going to be collected throughout in an aggregate way, no matter what language it was taken in.
Mm-hmm.
Um,
Mm-hmm.
and so we had certain targets, right? When you think about whenever you do a survey, what is the purpose of the survey? What's the targets? How do we know we're successful? So we set up some certain targets with our questions, really understanding what are the inequities in the rare disease communities, ensuring that we get the barriers to care and barriers to access answered.
Yeah.
So I think that's a little bit of the background in terms of how we were setting up the methodology. Now,
Yeah.
the second part to your question is how do we roll it out and how do we get it, to so many folks? Again, like you said, we beta tested this first with some of our community members, and that also reassured us that we were doing the right thing for either themselves because we had patients doing it, the caregivers, so the voice of either, the patient, the experience, and or perhaps speaking for a child or somebody else
Mm-hmm.
in that community. And then, of course, validating from our other patient advocacy organizations as well as they were part of the beta testing. So once we did that, we knew that we had a lot of different people that were also passionate, almost like ambassadors for the survey. So
Yeah.
then, so then we rolled it out just like that, just like you would do almost any other marketing campaign. You provide the social media toolkits, you provide the marketing materials, you provide the survey and the direct link. And we had our own website designed specifically for this survey to make it easy, right, for the
Mm-hmm.
responder to go into it. Um, and so everything was all on the digital platform. And so folks could go in there and answer the questions. I also want to underscore that we did not actually pay for anybody to do the survey. And it's pretty lengthy, and folks did it on their own. So it was because of great Samaritans like yourself, quite frankly, that you reached out to your community and said, could you please take the survey? Because I think it's really important for our broader community as a whole. So thank you to yours and your ripple effect to get this word out, because it really was many of the patient advocacy organizations. It was them that actually allowed us to receive almost 3,000 responders to the survey.
Yeah, that's amazing. And so it sounds like you guys, or I'm going to say we, as a small, tiny piece of the puzzle here, it sounds like, the effort was placed in advance to make sure, every possible um, idea. Every I, every was dotted, every T was crossed in terms of getting this survey out, which takes a lot of proactive planning. Were there any barriers or challenges? Did any of that pre-work expose anything that needed to be changed before it went out, or was it good to go and ready to send once all of the beta test results were in?
Yes, so I would say a couple of things. One is you're right, there's always some challenges along the way to ensure that it goes out in a timely manner. And actually, our timelines did get pushed out a little bit between making time for beta testing and also reassuring us that the questions were the right questions to be, or the best questions, I should say, the best questions to be asked during that time period. So I think there was a little bit of tweaks that was made during that time period. And then anytime you're going to do this in more than one language, you want to ensure that the translations are done in the best way possible as well. So there was some, delays in some ways to be able to do it both in English and then also in Spanish. I
Hmm.
also don't want to forget that we didn't just, send this out from a social media perspective, emails to you and your team, for example, but we also paid for Google Ads as well. So there was some paid promotion that we did. The Black Women's Health Imperative at that time had a digital billboard that we bought some of the time on in New York City at Times Square. So if you've ever been to Times Square, you know how bright and lively it is.
Yeah.
And then there's advertisements and other messages that come across more than just one advertiser, for example, with a still billboard. So we actually at one point owned some media space. Or rented, I should say, some media space out there. And so we took advantage of that. We also printed a lot of different postcards And we also mailed out a lot of different postcards as well. So there was some cost, not just digitally, that was involved in the early on. Um, you would not believe, I mean, I'm just so floored. And, you know, this marketing team that pulled this all together, how many, how broad the reach was in order
Yeah.
for us to receive 3,000 respondents.
Hmm.
And I have a background in marketing and advertising. And I was told a long time ago that, you know, you need to put something in front of people at least a dozen times before it actually resonates and sticks in their brain if it's something new. So we actually did Google search ads and YouTube ads for over almost 500,000 different ads and clicks and
Wow.
different ways of reaching folks in many ways, you know, and that's just, you know, two platforms there, for example. And then, of course, emails and the team, many of our coalition members, NORD, Black Women's Health Imperative, we were out there at conferences talking about this, promoting this as well. So for 6 months, we hit the ground running, right, for
Yeah.
this work, so that we could actually collect that 3,000 number. And I have to also say, within that 3,000 number, we actually were targeting only 2,000. So you
Yeah.
asked about barriers. We thought in the very beginning 2,000 would be a good number, and that about half of that should be from the historically underrepresented populations. When we saw us creeping up to 2,000 and we looked deeper into the data, we realized that it's often the same population that you can imagine that answers these surveys.
Hmm.
So we knew that we had to extend the survey time a little bit longer, go back to our community, do continue with our promotional strategy so that we could actually get closer to the 50% of the historically underrepresented populations. So the barrier was originally we thought we were going to only do this for about 3 to 4 months. It turned out we actually opened up the survey for I think 6 months or so, five to 6 months. So it was longer in that sense. So both the onset of being sure that the questions were right and then ensuring that we collected the data that we wanted as well. So both of that impacted the timeline. So, you know, a project when you originally set out to do this, you think it's going to take 6 to 9 months. And now
Yeah.
we've actually doubled the timeline to almost a year to be able to do this, to collect this rich knowledge of
Yeah.
information.
And I think, and we're going to talk about that next, the key findings from the survey. But I did want to point out, you know, I think as a patient advocacy organization, having marketing materials made it easy to share. You know, just the toolkit and even some of the printed material. You know, there was a call on a call to action on one of our planning calls, and if we were, you know, attending events or hosting events, you know, little postcards and different things could be mailed to us. And I know as an organization, we took advantage of that. And we had them on our display table at different events that we had, even in our local community, because you never know who your neighbors are, even if it's someone who's never received a service or a resource from the EWE Foundation. They could still be, you know, challenged in an area where this survey could still be something that they may want to participate in. And so, you know, I remember receiving our packet in the mail, and we had those leaflets available for people to pick up, and even if none of them felt like the survey applied to them, they still got that information and they were able to learn about the survey and some of the work that we are a part of. And so it was important to us to showcase that as we were out and about in the community. So, you know, it partnerships are always beneficial, but you know, to support work like this and not have to create things ourselves is huge. And I don't think, you know, some organizations realize how simple things like the information you want shared, providing that to advocacy organizations, it truly does help us get the word out because we're not responsible for creating that content or that information. So kudos to RDDC and NORD for making it easy to share that this survey was available for people to respond to.
Good. I'm glad that you found it really beneficial because we were very intentional to make it as easy for you all to hopefully be able to provide any answers to questions
Yeah.
that might come up. And all we wanted you to do was really just get the word out and cascade this to all your different connection points. And like you said, you never know, because not everyone talks about their healthcare. And in
Mm-hmm.
the communities that you and I serve and the families that we are part of, talking about health is really hard.
Yeah.
It is not something that we wear on our, on our shoulders or
Yeah.
anything like that. So, I truly believe that if we had the right and the best content and the communications, it just made your job a little bit easier and
Yeah.
the relationship there to help us with that just much easier. So thank you for saying that.
Mm-hmm. Mm-hmm. So let's shift to the key findings. And you've touched on some of this already, but just again, a recap. The study aimed to recruit 2,000 respondents, with 60% coming from underrepresented communities based on factors like race, ethnicity, sexual orientation, socioeconomic status, or residence. The recruitment targeted was surpassed. And among the respondents, the majority, which was 78%, were individuals with a rare disease, and the remainder of the surveys were completed by a caregiver for someone with a rare disease, and that was about 22%. And so, outside of just that preliminary, overview of the key findings, what else did this survey reveal from the respondents? Like, what else did we learn from it?
Yeah, absolutely. So I want to say that this report, in case anyone's curious, is on the Rare Disease Diversity Coalition's website. So you can dive in, and it's very active on our website as well. So if you're interested in learning more of what we're talking about here, it's the first glance of this report, because we've got lots of rich data, is available for public use, and also for not just for you to read it, but also for you to utilize it. As I mentioned, and your original
Mhm.
question was, who do you think could benefit from this? And,
Yeah.
as pharma and biotech companies are trying to figure out what's next for them, this data hopefully will be helpful. As patient advocacy organizations, whether you're an umbrella organization like RDDC is with rare diseases, or you are for specific rare disease, hopefully you can see some of the themes come through in your particular rare disease area. So, so we asked these questions knowing that there was going to be barriers to care, barriers to access, that rare disease patients and caregivers would feel. We actually came up with 14 themes specifically to what those barriers to care are. Just to give you a highlight of some of those barriers to care, which probably yourself and others could probably guess, when we think about the U.S. healthcare system. One
Mhm.
is, work. People that most people have to work, right? And so, how does your professional work, how does your employer help you or hinder you from some of the rare disease needs, whether it's through the clinical trial lens or through the insurance that you have? So employers, in some ways, and even time for, managing your health is a barrier. Um, as you can imagine, the expenses of clinical
Yeah.
care is a barrier. There's a huge psychology and anxiety and mental health component to this. And we'll get into this, I think, in a little while, because there's disparities or difference between those that are in the represented populations and the underrepresented populations as well. So anxiety, right, in the rare disease community is very, very real. When you think about the patients that are so lucky, if they are so fortunate to be able to be identified with the rare disease, then there's isolation that comes along with that, and that creates like some life management concerns, both as a patient as well as a caregiver.
Yeah.
And then your provider and the way that you're being treated, and certain perceptions that the patients have in their team, the team that treats them, for example. So we have 14 barriers. I just gave you a handful as an example, that came through in the survey. To your point, like I mentioned earlier, there is a real delta and difference between the historically represented populations and the underrepresented populations. So the data shows that you were overwhelmed from managing your life, like care itself, or caregiving responsibilities. And 50% of our respondents felt like that was a huge issue. And there's a delta between the underrepresented and the represented populations. So when I look at that particular theme, the historically represented or historically served population, about 42% of our data set in that group felt this way. But when you look at some of the diversity demographics, folks that are in the Hispanic population, over 60% of those feel this way.
Wow.
Time and time again, in many of these categories, when there was a delta in these different themes, the LGBTQ community actually often rose to the top. So again, in this example, if the question is about feeling overwhelmed in managing your life, in the LGBTQ community, over 70% felt like this was true. And again, in the historically represented populations, so those that don't identify in the LGBTQ community in this
Yeah.
case, only 41%. So that's a 30% delta or so between those two types of populations. So that just gives you a snapshot as to, I think, a little bit of how surprised many of us were for those that responded. And let me pause here to say that this was a nationwide survey across both the continental US as well as over to Alaska and Hawaii. We had very few respondents over there, but we did get a few respondents over in Puerto Rico, for example. I'm not sure. I don't think we hit Guam and some of the Samoan Islands over there. But in the United States, we hit, I would say, about 75% or so of our states as well in this data collection. So this is a nationwide problem.
Yeah. Yeah. Wow. Wow. And I've read I started reading through the report. I actually started reading through it before preparing for this call. I downloaded it and keep it on my laptop because one of the themes that we speak to um centers around health equity and and just the disparities of care. And I'm so glad that at the beginning of our conversation you highlighted that extends past just race. I think a lot of times when you hear diversity or equity, race automatically comes to the top of those conversations, and a lot of times other groups are completely dismantled or dismissed or honestly not even included. And so I think it's important, to talk about just all the different scopes of inequities, socioeconomics, and just all the things, a rare diagnosis even that can create some of these findings. So many people are experiencing these, and so wow, like I don't even think I realized that some of the numbers that you just shared, and I've read through the report. So wow, I'm glad you highlighted those. So just with next steps, every report comes to a close, but that doesn't mean the work is finished. What are the next steps for the report now? We know that it's available for people to use, but what is RDDCs and NORDs? What is the plan for moving forward, or the gaps that were identified? Is there going to be a targeted approach to do something with the information that we got? What are the next steps here?
Sure. So a few different things. And before I answer that, I wanted to go back to when you asked me about, who was these findings or this information targeted to ultimately. And, like I said, originally I thought it would be to scratch the itch and help the current coalition
Yeah.
members so that we can all rise to the challenge together with this data set. But also, we do have some folks in the genetic space, I want to say, that's a part of the coalition. And as we've discussed, you and I have discussed, right? It's genetics. So
Yeah.
many rare diseases, like 80% or so, are or 72% are of genetic origin originally, right? And when we looked and asked the questions in the survey about folks that, did you ever get asked about a genetic testing? 85% of those were never offered a genetic testing. So, I mean, there's a missed opportunity there. And so there's also an opportunity moving forward. So as we go into doing more of this work, I've asked the coalition and the working groups to think through how can we help our rare disease community, especially in the underserved population, understand what genetic testing is about and how can
Yeah.
we help them offer um, genetic testing more often. So I think it's twofold to your question is one, I didn't I didn't think that necessarily some of our audience members were going to be geneticists, those in the genome space, that kind of stuff. But clearly, because we asked the questions, so almost like if you look at those questions, any of the data collected, we could turn that over to that particular
Yeah.
industry and that population. Um, so in this case, yes, so our next steps is to look into some of the genetic testing opportunities. I would also say that looking at the working groups and the power and the coalition has so much opportunities. They're continuing to build awareness on this findings. And so there's opportunities for us to speak at different conferences and to share this information. So, the low hanging fruit is NORD has a huge summit every year, for example. And so last October, I shared some of this data at the NORD conference. RDDC, we will be on the Hill at the end of April, where we will do our first Hill debriefing. And we're using this inequities survey as part of that conversation so that policymakers that will attend or see at least maybe a debrief from the actual Hill debriefing, those notes from there can see this as well. Our policy team has also put together a one pager, for example, of this report, and we sent it out to the Rare Disease Caucus, which is a caucus made up of congressional members. So they have that too. So part of it is disseminating this information to other groups. And then when we put some recommendations in there and we put some resources, quite frankly,
Yeah.
in the report as well, so that it wasn't just, hey, this is the state of, but there are current resources out there that can help. So when we think about some financial barriers, there is a handful of patient advocacy foundations that actually help in this space for some of the specific rare diseases, for example, so to help offset some of those costs. So I think there's definitely more to come in solving for the things that we found. There's
Yeah.
more ways to share this information. So thank you again for having me a part of your podcast so that we can get this information out to those that are watching and listening in. And then there's going to be the opportunity to use this from a legislation perspective as well.
And I think all of those are so important. I will say, as we come to a close here, that we are one of those responders who did not get genetic testing. We were not referred to a genetic counselor. And I think we truly could have benefited from being connected and having that conversation. We actually did not even speak with a geneticist for the first time until Elijah was maybe 10 months old, before we ever even had a conversation with the geneticist. And so, y'all know my story, so I'm not going to get into all of that. But, I think it was just important to highlight that that's a really critical next step because families are getting diagnosis. In my case, I got Elijah's diagnosis in utero. And so, even getting a genetic diagnosis in utero, I was never connected with I was never connected to genetics or geneticist or genetic counselor. And so that's a huge gap. I'm bold enough to say that it's truly unacceptable. That should not have happened. But I'm jumping off my soapbox. So, and so, Jenifer has already said that the report is available on the RDDC website. I will make sure to put a link to the website in the show notes. I encourage you to go over and get the report. You can download it from the website, keep it in your toolbox, and use the information that's available. Leverage it to support the work that you're doing. If you're not in the health equity space, you don't have to be to use the information from this report. It's a lot of data that I think can support a lot of the work that a lot of patient advocacy organizations are doing. So, Jenifer, before we do our close out, do you have any final thoughts or anything that you want to share with our audience?
Well, the whole purpose of the coalition is to coalition build. And so partnering up with you and your foundation is an example of this. And so, for folks that are not familiar with our organization, if you see something that, that resonates with you and you want a coalition build, we also have a form on that website that you can then fill that out, and then we can have a one-on-one conversation as a potential new funder or as a potential new member for us. And like I said, it's because of the connections that we make in this work are we able to do all the different deliverables that you'll see on our website. And it's only because of, the great volunteers that we have and the great funding that we receive. So that's, for me, it's really important that RDDC hit 5 years next month, but
Yeah.
continues hit 5 more years after that, because it's not just here in the United States that we're making an impact, but we're making an impact globally. Because I brought this conversation to Europe last year and into India, and they found it really valuable because, again, they see so many of these similarities that's happened in their with their people, essentially, even though the healthcare is very different. But the isolations and the concerns and the psychological concerns and the mental health, all of that plays into no matter who you are and where you live on this planet. So I would say, yeah, if you want to continue to partner and find new ways to do so, we are absolutely open to having that conversation.
Awesome. Good stuff. Well, thank you so much for being on the show. I'm so glad to finally connect and share this report and just talk about it more in depth and all the stuff. So I really appreciate you hanging out with me today. All right, guys. We are at the close. If you are not yet following the Being Real podcast, you should be. Make sure you follow us. You can subscribe to our YouTube channel where you can see video episodes of the podcast, or you can find us wherever you stream your traditional audio podcast. All streaming platforms, you should be able to find us. Until the next one, be rare. Thanks. Bye. Peace.